Hi, everyone. Again, thank you for joining us this month for our Probing the Literature joint journal club. We will be reviewing OB-GYN cases today. As always, the schedule is we're going to have our first speaker discuss their article, and then we'll split up into we'll split up into small groups, and then we will discuss a second article, kind of come back together. And if anyone's interested, we will be hosting a methods consult, meaning especially if anyone has research ideas or things that are coming up that you are having problems with, please by all means stay and chat with some of the research experts. So as before, make sure you put your name, make sure you keep your camera on, mute yourself, and write how you are faculty or fellow or resident within ultrasound and emergency medicine. So our first article is going to be, we're going to be looking from the Journal of Ultrasound Medicine. It is by Dr. Derr, Determination of Endovaginal Ultrasound Proficiency and Learning Curve Among Emergency Medicine Trainees. As you can see, this is hot off the press, 2022, July. So we are very thankful to have Dr. Charlotte Derr here. She is going to be discussing this article with us. She has achieved ABEM focused practice designation in advanced emergency ultrasound. She not only serves as the fellowship director, but she also serves as the residency director at University of South Florida. I think that in itself is a huge commitment. So that's huge props to her. She's taught a variety of POCUS courses over the last 15 years, and she's heavily involved in the Gulf Coast Ultrasound Institute, where she serves as the co-medical director. She also has two proudest moments in ultrasound. The first one is actually completing this study, which took over 7 years, finishing the data collection for it, and as well as getting an emergency medicine physician performed TE resuscitation program at Tampa General Hospital in December of 2019. So among her roles, she's still active in research and active in bringing in huge components of ultrasound into the curriculum. And then probably my favorite fact about her is she loves ultrasound so much and is so dedicated to it that she's named her dogs after ultrasound. She has 3, one named Echo, one named Shadow, and one named Blue. Welcome, Dr. Derr. Thank you so much.
Thank you so much. It's a pleasure to be here. Let me work on getting the slides set up here for you. Give me just a moment. All right, can you see the slides okay? Looking good? Wonderful. Yep. Okay. Well, again, it's a privilege to be here. Thank you so much for the invitation. This project was a labor of love. It took a long time and a lot of ultrasound scanning to produce. So it really is a pleasure to have the opportunity to discuss it with you. I want to thank my co-authors who are on this paper with me, because without this tremendous team effort, this would never have come to publication. So let's go ahead and dive in here. So our main objective was to describe the level of proficiency and confidence of trainees after performing 25 endovaginal ultrasound examinations. And I'll use the term endovaginal and transvaginal ultrasound interchangeably. All right, and to introduce things, why do this study? Well, really, we felt that transvaginal ultrasound was perhaps more of an advanced skill. It wasn't as easy as learning a FAST exam, for example. And that was probably due to the anatomic variability that existed within the female pelvis. You know, there's a anteverted uterus and there's the retroverted uterus. The ovaries aren't always in the same location. They look a little bit different in different people. And that combined with the complex spatial orientation involved in manipulating a transducer in an area that it's hard to visualize where you are angling the sound beam and anatomically what you were looking at. We just felt that it was a little bit more of an advanced skill. So you've seen the memes. I love the memes that pop up, Instagram versus reality, where you've got this like glamorous shot, and then the reality of the situation looks completely different. Well, I feel like with transvaginal ultrasound, sometimes it's very similar, so that you have perhaps the Instagram or the Twitter or the textbook image of the long axis of the uterus. And then there's the reality of what you get when you scan that uterus, right? You're in with a trainee and it's heterogeneous and there's shadowing, and the endometrial stripe is harder to point out. And the same could be said perhaps of ovaries. You're all looking for this chocolate chip cookie appearance. It's this beautiful, perfect looking ovary. And then you go to scan, and in fact, getting that perfect looking ovary in reality is just a little bit more work. And then when you finally do get that ovary and lower your depth, it doesn't look at all like the textbook pictures. And I felt that that's what teaching transvaginal ultrasound felt like. So in reflecting back on the recommendations by the American College of Emergency Physicians, they were having kind of a 25 plus 10 recommendation, where if you've done 25 transabdominal pelvic ultrasounds and you've started to learn and understand what the anatomy looks like, the echo texture, then perhaps maybe a minimum of 10 more would be sufficient for getting credentialed in transvaginal ultrasound. So applying your knowledge transabdominally to the endocavitary approach. And the authors in the study really felt that we disagreed with that, and it was probably more than that was required to become proficient. So it's imperative for emergency physicians learning transvaginal ultrasound to be confident as well in performing the procedure, as in addition to being accurate in their examinations. And no prior study had evaluated or looked at the proficiency of trainees after performing 25 transvaginal ultrasounds, but we kind of had these blanket recommendations that 25 of most emergency medicine applications seem to be kind of the target number for proficiency. Now, there was a prior study that looked at our ability to identify IUPs and ectopics, and that study reported that proficiency occurred at greater than 40 exams. And so we felt that the learning curve existed past that 25 plus 10 recommendation that was in the ACEP white paper. So let's talk about the methods for this study. It was an IRB approved prospective cohort study of emergency medicine trainees at a single urban academic emergency department. And the study consisted of 5 residency classes and fellow classes, essentially taking 7 years, since it's a 3-year residency program. That last class was enrolled, and then 2 additional years to finish for a total of that 3 years of that class. So overall, 7 years, a total of 50 residents and fellows. There were some people that had dropped out and for other reasons. One was a fellow who scanned so much clinically that we didn't feel it was right to include her small number of supervised exams into this study. And we had a couple of residents that weren't able to finish the study. So all in all, when those were removed, we had a total of 50 trainees and 1,117 supervised transvaginal ultrasounds that were performed. So the trainees and fellows came from our emergency medicine residency or from our ultrasound fellowship. To be included, they had to have done fewer than 10 prior ultrasound examinations that were TBUS in nature, and none of them even came close to that. The most that a trainee had was 1 or 2 hands-on exams. A couple of them had been present and observed others doing it, but nobody fell out of that qualification. They participated in a 2-day intro ultrasound course, and one of those didactics covered in the course was 1 hour on GYN ultrasound, covering TBUS anatomy, pathology, and the hands-on portion of the day, there were 2 live models that the participants scanned as well. So going through the rest of the study design, each trainee performed a minimum of 25 TBUS in a OSCE style. So these exams were done on paid models, and there was the supervision of an expert present. And each exam was scored for agreement of exam findings between the trainee and the expert. And we also asked for the trainees to score their confidence in the different areas prior to performing the examination. So that the survey questions were grouped corresponding to specific components of the exam. So we looked at things relative to their ability to identify the uterus and the uterus structures. Could they find the uterus, for example, on the long axis, the short axis? Could they identify the fundus, the endometrial stripe? the cervix, the posterior cul-de-sac, and that was grouped into the uterus category. And then there were questions about directionality. Could you indicate the directionality on the long axis and the short axis? And those were lumped into directionality category. And then they were asked to point out the right ovary and the left ovary in both the coronal and the sagittal imaging planes, and the ovaries were lumped together in an aggregate category as well. And the confidence in those same areas were into aggregates too. So the data was used to develop a performance curve identifying when proficiency was achieved and where additional experience showed a diminishing benefit. And we looked at where they felt confident. Now, you may be asking, how in the heck did you come up with all those ultrasound models? And that was actually the most laborious portion of the study, was just to get different pelvic ultrasound models, because we didn't want the trainees to scan the same model twice. We wanted 25 different examinations. So the bulk of our models came from advertising on Craigslist. And you might be asking yourself, where on earth would you put this in Craigslist? It felt right to put it in the etc. category. So that's where you would find our job posting. Our participants, our models were over the age of 18, premenopausal. They couldn't be pregnant. We wanted to make sure they had their uterus and both ovaries there in order to participate. And we did not hand select or pre-scan our models for the ability to visualize anatomy. So whatever was signed up for the day was the model that you scanned. So we weren't self-selecting easy anatomy to identify. We wanted it to be as much as it could be like a person who would walk into the emergency department. So we were looking for people who had easy to find ovaries. We wanted all comers to represent the reality of what it's like to scan different anatomy for pelvic ultrasound. And as I said, we wanted to make sure each model was scanned only once by each resident. So when it came to the statistical analysis, our statistician recommended that we do a scatter plot method to generate a model of performance for each aggregate category type. And then we looked at the percentage agreement with expert review and also the confidence, and plotted those as a function of the total previous number of transvaginal ultrasound examinations. And we also developed plateau points and looked at those performance curves to see where the experiential benefit diminished or flattened. So here were our results, and we selected 90% as our proficiency definition, and we took that from 2 articles that had been published by Jang and one by Blehar, and 90% is what we used based on those articles. So if you take a look at the bottom here, where we have the number of endovaginal examinations performed over time and then percent agreement, you can see that as our trainees started to approach 25 at the end of the scale, they were easily crossing over that 90% threshold when it came to their ability to properly set up the machine, position the ultrasound, manipulate the probe appropriately, identify the bladder, and correctly identify directionality. It took a little bit longer, as you can see with the orange, for them to correctly identify all the uterine structures consistently and pass that 90% threshold. And then the more yellow color is the aggregate ovaries. So looking at 25 examinations and how proficient they were, it was only about 76% for that aggregate ovary category. So what do I mean by aggregates? Well, the aggregate data for the ovaries required 4 skills. So you had to identify the right and the left ovary, both in coronal and sagittal planes. So that was 4 skill sets. And if you identified one incorrectly, then that exam was considered incorrect. But we took this aggregate agreement and we've set it aside for the moment and also broke it down by just the individual components. So if you look at their ability to identify the right ovary in the coronal plane, the sagittal plane, and then the left in coronal and sagittal, you can see as they got towards 25, that number became close, if not reaching 90%. If you take a look at that mean, the mean is actually 89.3%. So not quite our 90% threshold, but it was getting better and better. But as an aggregate group, it was only 76%. So looking at this a different way, looking at this table, the percent agreement you can see is in the 90s for all the other areas except for ovary. But take a look at the plateau point. So they, as far as setting up the machine, they started to really do a great job and not really benefit from further experience after about 10. for identification of the uterine structures correctly and the uterus itself correctly, that aggregate category, that plateaued at 11, and then it kicked up again with more experience, and it started another incline. As far as requiring them to identify the bladder, the plateau point was at 17. Ovaries, it plateaued at 16. And then I'll show you that graph, how it starts to slightly go up towards when we get towards the 25th exam. And then imaging plane identification plateaued a little bit later. So if you take a look at their ability to identify the uterus, the number of scans at the bottom here, and a percent agreement on the vertical, there was a plateau about 11, but then as they had more experience and more reps under their belt, then it started to go up again. And we anticipate that's what it would be like with the ovaries. You can see the ovaries plateau benefit about 16, but then it starts to incline again. And later we will actually produce data in a future study to show that that continues to go up towards 30 to 40 scans. And it's around in that 30 to 40 range where they start to cross over that 90% agreement threshold, but it doesn't occur until well after 25. When you take a look at confidence, these trainees felt most confident after 25 exams when it came to things like setting up and inserting the probe properly, being able to identify the bladder and the areas of the uterus. But looking at the other end of confidence, what they did not feel most confident was their ability to identify abnormal pelvic structures, their ability to adequately identify the ovaries, or to perform the exam in a reasonable amount of time or without supervision. So this is using that 5-point Likert scale. So 5 meaning I feel incredibly confident and ready to go, and 1 meaning I always need help, I don't feel confident at all. So lower scores in confidence for the ovaries and the ability to perform the exam independently and feel confident with their results. So let's go ahead and roll into discussion. As far as performance is concerned, this study demonstrated proficiency after 25 exams and their ability to prepare and insert the transducer, identify the bladder, the uterus, and to adequately indicate directionality in the sagittal coronal planes. Their ability to identify the uterus briefly peaked or plateaued at 11 exams, but then began to rise until about 22 exams, at which point they crossed the proficiency of 90%. Proficiency was not achieved for identification of the ovaries, suggesting there is a learning curve which persists past 25 exams. And we suspect that it'll be a similar phenomenon like that of the uterus, where it plateaus briefly, but then more experience and time and more repetition then causes that agreement to go ahead and go on the incline past 90%, but a future study will need to show that. So as far as confidence, despite performing 25 supervised examinations, the participants never reached an area of confidence in the areas of their ability to identify the ovaries, identify normal and abnormal pelvic structures, to perform the exam unsupervised and in a reasonable time frame, or their ability to use this modality diagnostically. And this was really concerning. So the limitations to this study, it was a small study at a single site at Tampa General Hospital. It's unclear if our methods of teaching transvaginal ultrasound was optimal. There aren't a lot of national recommendations for the best approach to teaching TVUS, and that's something we discuss more in the paper. There's certainly some recommendations from ACOG, ACGME, and AIUM, but no consistent recommendations. Our trainees in the study were enrolled right after their introductory ultrasound course, so they had introductory level ultrasound experience when beginning the study. The OSCE exams were performed at irregular intervals at, to be honest, times that were convenient for the supervising faculty involved. A Likert scale was utilized to collect the data on confidence, which if we perhaps rather than using a 5-point scale had used a larger scale or performed interviews with the trainees, we might have been able to provide better data in regards to confidence. And some people say that one of the limitations might have been that our models were not pre-scanned and therefore had less pathology, but I actually felt it was a benefit to have models that were not pre-scanned or self-selected, and that would more represent the general population that could show up at the emergency department. So what were our conclusions in the study? We felt that this particular exam had a significant learning curve to perform properly for many reasons. that identifying the uterus for intrauterine pregnancy seemed like an obtainable skill after 25 exams, and therefore it could be learned early in training. We felt that the adnexal evaluation remains a challenge after 25 proctored exams, and that our data did not support the use of 25 exams as a benchmark for proficiency in transvaginal ultrasound. Now, despite many discussions on how best to deliver TVUS education, there's currently no agreement. And we feel that the current ACEP guidelines are likely sufficient for uterine application, but we still don't have defined minimums for what is required for identification of the ovary and ovarian pathology. And we hope that one of our future studies will look to define that number. And I open the floor for any questions about the presentation.
Great, thank you so much. It would definitely be very interesting to apply it at various sites, kind of similar to with some of the cardiac studies where it's a multi-center, and apply the same protocol and see how it would work there, especially if it's a site that's not university based, but a community site that still has residents and fellows too. If anyone has any questions, please feel free to put them into the chat box, or you can just unmute yourself and please speak up.
I'm just super impressed you got that many TVS models. We tried something similar with that, and the two models who showed up, one of them didn't have a uterus and the other one had horrible fibroids. So
oh gosh,
that's
yes,
awesome.
There were some challenging days for sure, and if for some reason we couldn't see a right ovary or a left ovary in a particular model, then it just wasn't scored for that. So we figured if the expert couldn't find it, we certainly didn't expect our trainees to find it. But yes, you named it. You've got all sorts of variation in anatomy that comes in, and lots of fibroid uteri and interesting looking ovaries. So, and what I learned in getting models in that particular fashion was I always booked twice as many than I actually needed, because we also had people that would cancel at the last minute as well. So that was another thing that I learned. You'd have 4 proctors there, and then only 2 models show up. So we would book twice as many as we needed, and then figure it out from there. If we had too many, we figured that was a good problem to have.
I'm curious, have you looked at these residents' practice going as, you know, they finished their residency or continued on with the residency? I'm not quite sure about the timing of when these were all done, but did it affect their practice and actually doing transvaginal ultrasounds? Because I know, you know, a lot of residents who don't have experience are really reluctant to do them. So there aren't a lot performed.
Only anecdotal reports. So these grads are now out 5+ years, and the fellows more so, of course, would be using, as you might anticipate. But we did have some people end up in rural locations where they didn't have 24-hour ultrasound that did send me some text messages saying, you know, I really hated this study at the time that you did it, because it was one of the things I did not look forward to most. But now I'm really glad that you had me enrolled in that study, because now I'm able, and I feel more comfortable doing them on my own when I don't have somebody that's available 24 hours a day at our facility. But yes, the residents also felt that it was a labor of love, as did the faculty, and they nicknamed it TV Tuesday. So they're like, are we having TV Tuesday next week, Dr. Derr? Are we going to be able to get those exams done? So it was kind of funny.
Wow. And over what course of time were the exams completed? Was it all during like the first year of residency, or did it?
It went across all 3 years.
Okay.
Yeah, all 3 years. Because you know the way the academic cycle works, there's sometimes that are just, you're way busier than others. And so you would try to squeeze them into the periods of the academic calendar where you knew you could get your faculty and your fellows all in the same place, able to help on the same day at the same time, usually on Tuesdays, and try to get as many residents there. And so we would send out text messages and emails to let the residents know which teaching area of the hospital we would be in, what times we would be there, and they would come off service. They would tap out for 10 minutes clinically to run down and get them finished, particularly if they were graduating, because they really wanted that 25 for their credentialing purposes in their future as well. So they also felt that pressure, not to get only to help us finish the study, but to be able to have that logged and QA'd for credentialing purposes in the future.
Cool.
Yeah, I think it'll be really interesting once you start getting text messages from all these residents, a few years out, when they're actually using it out in the real world, just when they end up at places where, their decision, their ability to take a quick look will potentially, either save the patient or help dispo them quicker. So my feeling is that in the future, they definitely will be very thankful for the study, like you're saying, that you've already heard some of those people. But especially from our residents, we can't predict what comes into the ED, and from month to month, sometimes we'll have a whole bunch of OB patients or even GYN patients, and other months we'll have none. And so the residents' education varies so much. We've tried to do a little bit of a sim component to it with SonoSim. I don't know if you looked into with education for the residents in regards to these models, any of that curriculum or anything like that.
Yeah, we had actually used the Blue Phantom model before, but in developing the texture vision requirement for pulling that adnexa out of everything else in the pelvis and the bowel surrounding, it just doesn't really represent that realistically. I don't know. What did you guys think as far as our numbers in the study, those that have been doing transvaginal ultrasound for a while on non-standardized patients? Do you agree that it takes longer to get that skill, that ovary vision, that pull that structure out? I mean, it's been my experience, they'll call uterine vessels ovaries, or sometimes it's bowel they call ovaries, or sometimes that ovary is snug in and camouflage right along the wall of the uterus. So I just doesn't 25 just never felt right for us, which is why we did the study. It looks like there are some nods. That's good to hear that there's some agreement there.
Yeah, I think for our residents, I can say that I feel with 5, I feel comfortable with them identifying intrauterine pregnancy, but for most of them to be able to identify ovaries is pretty non-existent in residency.
Yeah, I think, yeah, I mean, I find it's a stretch. And like you said, the number that each resident gets is so variable. I mean, the ED is so different, as far as when we have a bunch of pregnant patients versus when we don't.
Yeah.
So they get
and I was gonna say, and actually I think the pregnancy actually helps, because at least you usually have like a corpus luteum to draw your eye to the adnexa.
Yes.
Whereas the non-pregnant patients, I think, are just more difficult.
Definitely. Yeah. And I think somehow it's a little easier when the uterus is a little bit larger. I don't know why that is, but I guess it maybe pushes the bowel out of the way. I'm not sure, but definitely. And just like any other ultrasound skill, some residents pick it up much quicker and some residents never really get the orientation. So that's also, is with all of the ultrasound things that we do.
Yeah, the mechanics of the probe movements is just different from anything else that we do in emergency medicine, I feel.
Mm-hmm. Yeah, we had these small sonocytes, and you could pull them off the stand, and for people who are really having difficulty, I would like turn the ultrasound so they would have the same orientation on the machine as they did with the patient. But now we have these bigger machines and I can't actually turn the image.
It's a good idea though.
It works.
Again, thank you so much, Dr. Derr, for joining us today, and congratulations on finishing this study and publishing it. It's very, very impressive. Again, if anyone has any questions and they didn't get to ask them today, please, by all means, feel free to email us. as you saw earlier, we have Dr. Derr's email on here as well. And we're going to go ahead and start part 2.
Thank you, everybody.
So there's Dr. Derr's email and then her actually Twitter handle too. If anyone has any interest or any further questions or wants to expand this study protocol to your site. For our second article, we're going to break up into small groups and we're going to talk about an RCT that was from 2018, also in the Journal of Ultrasound Medicine by Dr. Morgan. It's the effect of emergency physician performed point of care ultrasound versus radiology department and length of stay for pregnant females that are less than 20 weeks gestation. So Dan's going to go ahead and break us up into the small groups. And we'll have probably 15-20 minutes to discuss this article.
And then please just bear